Orthopaedic Society and Maharashtra Orthopaedic Society. I must welcome all the panelists and the speakers, and a special thanks to Dr. R.C. Meena, President of Indian Orthopaedic Association. We are
Pranam, sir. Pranam, everybody. Pranam.
Namaskar, sir. Sir, you are welcome at this, sir.
Thank you, sir. Thank you.
Sir, you are welcome at this, please, sir.
So, good afternoon, friends and the learned faculty and of a international repute. This is very nice to see all of you. As though the battle has been finished, but the warriors are not still on the rest. They are still continuing and doing exercise for the another innings or field. And similarly, that the mission to educate the orthopedic fraternity across the country is on the boom, and that the arthroscopic surgeons with the Indian Orthopedic Associations are doing well, with rubbing shoulder to shoulder and joining the hands. Indeed, it is very pleasure movement to see Dr. Samanta, Dr. Abhijeet, my friend IPS, Dr. Mukesh, and Dr. Antao sir, and great Dr. Sanjay Desai sir, and Ashish as well, sir, please. Ashish and young man, and Dr. Pradeep Nimade. I used to listen their name and see many of them on the either screen or on the literature, but today I am happy that they are all in front of me and on the screen. And I welcome all the viewers and the listeners, those who are connected with the this webinar, online webinar, or of the screen. So I wish you all the best, and definitely hope the viewer and the listeners will benefited in the field of arthroscopy, and the mission will be continued for a victorious end. Thank you. Keep it up.
Thank
all
you,
the
sir.
best. Thank you very much.
Sir.
All the best to all of you, sir. Thank you, sir. Thank you.
Thank you, sir. I know that you are today. You are extremely busy. Still, you have
exactly, sir. Today, my family, a small function is there, and
you,
I am presenting it from my house. My family is on the another house.
Absolutely,
for
sir.
a small function.
Thank you very much for sparing your valuable time. We appreciate. Friends, let's welcome our moderators for this day today. Dr. Nicholas Antao from Mumbai and Dr. Shaikh from Miraj is going to join soon. I thank Ashish Babhulkar for putting up the excellent faculty here and the program. And we have speakers from Mumbai, Dr. Abhijeet Kale, Ashish himself from Pune, Dr. Mukesh Laddha from Nagpur, Dr. Sanjay Desai, the Doyen of Arthroscopy from Mumbai, and Dr. Nagraj Shetty, a young dynamic arthroscopy surgeon from Mumbai. The topic is young arthritic shoulder, and I think this is something quite interesting as far as the presidential message of preventing joint deformity is the presidential theme. It matches well with it. May I ask Ashish to kindly introduce the topic and then go into the flow of the program. Ashish, please.
I think I would say, since the BOS people are not there, on behalf of BOS, I welcome the faculty here.
Thank you, sir.
Maybe on behalf of my friend Dr. Ajit Shinde, who is the president of MOA, I welcome the listeners as well as the galaxy of shoulder surgeons. Who's who in shoulder surgery?
Yeah, all here on the single platform. Thank you very much, sir. And
thank
I think
thank you very much.
This is basically a great honor on the part of the Indian Orthopaedic Association and also the Indian Arthroscopy Society, because probably the first time the Indian Arthroscopy Society is celebrating the Bone and Joint Week, and this is a huge honor that we are celebrating with mostly all the states. And today we are celebrating with Maharashtra Orthopaedic Association along with the Bombay Orthopaedic Society, and my guru like Antao sir is one of the gurus, so he is there. Sanjay is a very close friend, or all rest are very closely. We are working in the IAS group. So I welcome you all on behalf of the Indian Arthroscopy Society, and I am really grateful to Professor Meena. He has joined and gave his presidential message. So Ashish and Nicholas, it's all yours.
Thank you very much. Thank you, IOA, MOA, IS, all the office holders. This is a rare opportunity. And I think, correct me if I'm wrong, but this is the first time IAS, and on this platform, we are conducting young osteoarthritis, which is a topic that has not been covered in the past so far. Yeah. So this should be a very unique event. And we'll probably cover this entire topic, which is a very challenging, difficult topic, and have designed the program in such a way to cover all aspects of it, right from the clinical diagnosis to the minimal invasive to replacements and the role, and plus look at the evidence and is there a future for this, because this is a topic that is not often discussed. It's a very complex topic, and I don't think we have a silver bullet to address this issue. So those of us who are here, please listen with great intent, because we're about to learn from some very expert faculty. So without any delay, I will not like to come in between you and the academics. So I would like to invite Abhijeet Kale to speak on clinical diagnosis and investigation in view of a young arthritic shoulder. We are talking about patients younger than 50 years old. Thank you, Abhijeet.
Good afternoon, everyone. At the onset, let me thank the Bombay Orthopaedic Society, the Indian Arthroscopic Society, the MOA, the BOA, the MOA and the BOS for giving me an opportunity today. As Dr. Ashish Babhulkar, the leading arthroscopic surgeon from Pune, has rightly pointed out that a young arthritic shoulder is a burning topic. Am I well audible to everyone? Hello?
Yes, you are very well audible. Yeah, you are well audible.
And is my screen also very well seen?
Yeah. Yes.
Yeah. Thank you for the feedback. So to start with just one point about anatomy, the shoulder joint is placed in retroversion, and glenoid contributes to just 3 degrees and the humerus contributes to 20 to 30 degrees of retroversion. As we know that the hip joint vice versa is placed in anteversion. In the shoulder, it's exactly reverse. It's placed in retroversion. The shoulder arthritis can be broadly classified into primary and secondary arthritis. Primary arthritis is an idiopathic arthritis, which we see beyond the age of 60 years, for which a cause is not known. Vis-a-vis, a secondary arthritis is the one where the cause is known, something like post-traumatic or because of avascular necrosis or rotator cuff. There are multiple reasons for secondary arthritis. Also, shoulder joint or the shoulder arthritis can be broadly divided into acromioclavicular arthritis and glenohumeral arthritis. Now, if we go through the literature, this term young arthritic shoulder is very well described, and it mainly points to that group of population which is below 50 years of age and which predominantly involve the glenohumeral arthritis. So in this talk, we will be restricting ourselves to glenohumeral arthritis in an age group below 50 years of age. Now, it's said that usually young arthritic shoulder is diagnosed accidentally when one performs arthroscopic surgery for some other reasons. Also, another point to be noted is if we compare a shoulder arthritis vis-a-vis with knee or a hip arthritis, in knee and hip arthritis, those joints being a weight-bearing joint, the symptoms, they tend to be proportionate to the radiological findings. Vis-a-vis in shoulder joint, which is a non-weight-bearing joint, the radiological findings may be far ahead compared to the symptoms of the patient. Now, this in the young population, there are various etiopathogenesis for this arthritis. There are certain professions like sports person and construction worker in which this is common. If we look among the sportsmen, especially the overhead sports activities like baseball, lawn tennis, volleyball, they are usually predisposed to this. Also contact sports like football, rugby and hockey. Sports person involved in these sports have also been found to have a higher preponderance to arthritis of the shoulder. And finally, the weightlifting, where the weight comes directly on the shoulder. Now, coming to the etiology of the young arthritic shoulder, it can be broadly classified into traumatic causes and non-traumatic causes. Among the traumatic causes, it can be either following a fracture or a dislocation, or both fracture dislocation. It can also follow a repeated or a recurrent dislocation of the shoulder, where it's known as post-instability, Also, in case the implant breaks and the screw penetrates through the head and erodes the humerus or the glenoid cartilage, one can land up with an arthritic shoulder. Also, a capsulorrhaphy, which is done to treat an instability of the shoulder, can also lead to an arthritis if not done in the right way. Rotator cuff injury in a young population can predispose again to arthritis, and avascular necrosis. This is common to both traumatic as well as non-traumatic, because the causes for avascular necrosis can vary. The other causes for non-traumatic arthritis are inflammatory disease like rheumatoid arthritis or ankylosing spondylitis. Ankylosing spondylitis mainly involves the axial spine, but when it involves the appendicular region, it can involve the root joints like the hip and the shoulder. Also, metabolic causes like gout and pseudo-gout. Even infection can predispose to a shoulder arthritis like tuberculosis and non-tuberculous causes. Also, glenoid dysplasia, which is a hereditary condition, can predispose to it. And to complete the list, even a neuropathic joint in a young person who has developed a diabetes at a young age group may lead to it. Now, let's see what are the traumatic causes. Dislocation arthropathy, what we call it as. One develops arthritis because of repeated injury to the joint cartilage. In this, there is an abnormal loading on the glenoid head. The incidence is found to be higher if one develops a dislocation at a younger age. Also, the incidence is found to be more if one develops a posterior dislocation of the shoulder compared to anterior dislocation. Another point to be noted is arthritis cannot be correlated to the number of dislocations. In one of the studies which has followed up the patient over 25 years, they had found that almost 56% of the individuals who had developed a dislocation or undergone a surgery for that developed arthritis of the shoulder. Another common cause is the rotator cuff injury. If usually there can be a dysfunction or a large tear, and if this goes undiagnosed, untreated, then the humeral head tends to migrate superiorly. It impinges upon the acromion and the superior aspect of the glenoid, and thereby leads to erosion of the cartilage. Usually the patient presents with inability to abduct the shoulder. Now there are various stages of rotator cuff arthritis, broadly divided into two types. One which are centered and one which are not centered, that is centered and decentered, and each is divided into stable and unstable type. Also, when one develops a recurrent dislocation of the shoulder and then undergoes a surgery for that, if this surgery is not done properly, one can still end up with arthritis, which is described as post-capsulorrhaphy arthritis. This usually occurs because excessive tightening of the joint capsule. This pushes the humeral head in one way and causes an wear. So now this can be, the primary instability can either be unidirectional or multidirectional. If it's a unidirectional instability, and if in the surgery there is an excessive tightening done, then invariably the external rotation decreases. This concentrates the forces, mainly the compression and the shear forces, and leads to a glenoid wear. Vis-a-vis, if it's a multidirectional instability, then during the surgery or after the surgery, after the tightening is done, the head is displaced. And again, there is an eccentric loading on this head, which leads to a wear and tear. So if we look at the surgeries which are done for the recurrent dislocation of the shoulder, the Bankart surgery is the one which is associated with the lowest risk of developing arthritis. Vis-a-vis a Laddha surgery, it is associated with a medium risk. But if a person has undergone a Laddha surgery, there is a chance that he will have a glenoid loss. And also, if after undergoing this surgery, if the patient has developed arthritis and you have planned a certain procedure, one should remember that the planes may not be good. Another point is the high risk of arthritis is associated with Dutiplat brista. Coming to avascular necrosis. Avascular necrosis again can be unilateral or bilateral. Usually when it is unilateral, the cause is traumatic, and when it is bilateral, the causes are systematic. There is a disruption in the blood supply which causes cell death, and thereby the collapse of the subchondral bone and invariably leads to arthritis. Now, the traumatic causes are a fracture or a chronic unreduced dislocation, while the non-traumatic causes are if the patient has alcohol, if he is a chronic alcoholic, if he has developed certain hemoglobinopathies like sickle cell anemia, or there are clotting disorders, or he has been taking steroids for a long time, or a metabolic or a idiopathic cause. Before we move to the non-traumatic causes, let's try to understand what is chondrolysis. Chondrolysis is a destruction of the joint cartilage, but there is not much of osteophyte formation. If there is a chondrolysis with osteophyte formation, then we term it as arthritis. Usually this condition can be seen following a history of arthroscopic surgery. There are certain factors which have been linked to chondrolysis. Some of them are if an intra-articular anesthetic drug has been given for a long time to control pain. Certain biodegradable anchors are known to predispose to it. A thermal injury or a radiofrequency injury can also lead to it. A low-grade infection which might have gone undiagnosed, untreated can lead to chondrolysis, and also some contrast have also been attributed to it. Coming to the non-traumatic causes, inflammatory causes, mainly rheumatoid arthritis and ankylosing spondylitis. They can either be juvenile onset or adult onset. Usually a juvenile onset inflammatory arthritis will lead to a bony ankylosis, while an adult onset rheumatoid arthritis will lead to a fibrous ankylosis. Now here there will be an involvement of the joint as well as the soft tissue. It is found that shoulder is involved in almost 90% of the cases. So this is hard to believe. There is a concentric decrease in the joint space. There is a central wear of the glenoid and the humeral head gets medialized. Also, this condition is characterized by poor bone quality. Coming to the crystalline arthritis, which is usually called by a gout or a pseudo-gout. Gout is because of the deposition of sodium urate crystals, and pseudo-gout is because of calcium pyrophosphate crystals. And to complete the list, then we also have a glenoid dysplasia. Now, glenoid dysplasia is the condition in which the posterior inferior part of the glenoid isn't developed. It's a malformation, and it may or may not be associated with even a scapular neck malformation. To compensate for this, there is a labrum hyperplasia. So this patient do not present immediately at birth or in the first or second decade. They start usually presenting after third decade, and this condition is best diagnosed with a CT scan. Coming to the clinical examination of the young arthritic shoulder, a patient will characteristically have a shoulder pain. One should try to know the quality, the timing, the aggravating factors, and the localization of this pain. To know the cause of the arthritis, one should take in detail the history of trauma or a history of repeated episode and the time of onset. If you are suspecting AVM, then you should rule out the causes which lead to avascular necrosis. And if the patient has undergone a previous surgery and one is thinking in terms of infection, then one should ask for a history of any fluid aspiration, any wound healing. Was there a problem in wound healing? Was a repeat surgery done, or were there any signs of low-grade infection? Coming to local examination, if a previous surgery has been done, one should examine the previous surgical wound. One should check for range of movement and especially the external rotation, because it's the anterior shoulder capsule which contracts and limits the external rotation. And if anyone is contemplating a surgery with a restricted external rotation and taking an anterior approach, probably one will have to take a help of a nerve monitoring. Also, rotator cuff strength, subscapularis function, and axillary nerve should be properly evaluated. So to complete clinical examination, one should check for the joint stiffness, activity restriction, look for crepitus, night pain. This is usually a sign of late stage wasting of the shoulder girdle muscles, which will indicate the chronicity, weakness of the muscle, joint line tenderness, range of movement both active and passive, and also involvement of the other joints. So if a patient has the involvement of the acromioclavicular joint, patient typically points at the pain at the top of the shoulder, which radiates to the neck. Vis-a-vis, if he has a glenohumeral arthritis, he typically complains of pain at the back of the shoulder, which worsens with weather, and it's a deep aching pain. While
Abhijeet?
if a patient has a rheumatoid arthritis, he will have both a glenohumeral as well as the acromioclavicular type of symptoms. Coming to the investigation part, there are various X-rays done. Typically, we go for
Ashish, you are not audible there.
Am I audible,
Sorry,
sir?
Abhijeet? Yes, you are
sir.
audible, Abhijeet, but we need to wrap up. We need to give time for all the other speakers.
Sir.
So can you just conclude? Yeah.
Yes, sir. So the investigation parts, it's mainly X-ray, CT, and MRI. These are the in the X-ray we get a AP view and the lateral view. In the AP view, if there are large osteophyte, it indicates dislocation. If it's a small osteophyte, it indicates inflammatory change. And if there are circumferential osteophyte, it indicates a primary OA. If we look at the migration of the humeral head, superior migration indicates rotator cuff arthropathy, medial migration indicates glenoid hypoplasia, and superior plus medial indicates usually a rheumatoid arthritis. MRI helps in knowing the integrity of the rotator cuff and subchondral bone loss. CT scan will tell us about the bone loss, especially the glenoid version is best plan on it. And if one plans to rule out infection, one can even aspirate the joint and do the infective marker. So to conclude, the take-home message is there are various causes, traumatic and non-traumatic. Investigation remains the mainstay, and if one is contemplating a arthroplasty, one should go for a CT scan. Thank you. So I will unshare my screen.
Okay, thank you, Abhijeet.
Yes. Thank you, Abhijeet.
I will unshare my screen. Yeah.
Yes.
Thank you. While others come in for questions, Abhijeet, I would like to make a point here that the arthritis, which is typically young patient arthritis, is a little different. It's early disease. It's not as proliferative as elderly. And I would say Bankart Latargy have a equal risk. We're talking about well done Bankart Latargy. If Latargy is not done well, then that's another moot point. But the Swedish study from Hovelius told us that the arthritis risks are pretty similar from both. There's very little difference between the two of them. But I understand what the point you were trying to make home is putty-plat can be absolutely sinister and the results are capricious. So putty-plat, of course, fortunately, not a very popular one. Any other questions for Abhijeet?
No, I think Abhijeet covered well. Abhijeet covered the most of the things.
Yes. Lovely. So if there are no questions, then I'll move on to this topic. This is
yes, Nicholas sir, you are muted.
Nicholas, yes, sir, Nicholas, you are muted.
Can you hear me now?
Yes, sir.
Yes.
Well,
in bipolar lesions of the shoulder dislocation, both humeral loss as well as glenoid loss, how often the esteemed faculty sees arthritis?
So I think, Nicholas, you can see chondral damage even without bipolar or glenoid bone loss. Let's not mix the two because some amount of Hill-Sachs is always going to present in every instability. But they're not. Chondral injuries are very rare, but when they are, then they get neglected. More the recurrence, more chances of repeated chondral damage as such.
Yes, obviously, Nicholas sir, as you are mentioning that bipolar lesions in the shoulder is obviously there is higher chance of getting the arthritis. Because every time some people believe that not a single Hill-Sachs is non-engaging. Some people tell all Hill-Sachs has to engage somewhere. So definitely if there is Hill-Sachs, whether engaging or non-engaging, be a higher risk of getting the arthritis rather early.
I don't think so, Swarnendu. Let's not mix instability with chondral damage.
No, he is asking about the bipolar, he is asking about the bipolar lesions like glenoid bone loss and the Hill-Sachs. I think Nicholas sir, you are asking on that, no?
Nicholas?
Huh?
Nicholas sir, you ask about the glenoid bone loss along with the Hill-Sachs, no? That is the question?
Exactly.
Okay.
The other question I have is, we get chondral damage in this situation which I mentioned here, but very rarely in multi-axial instability, global instability, we don't get. What is the reason for that?
Well, part of the reason I would say is that they are not stiff patients. The incidence of cartilage damage is more likely in stiff patients, violent injuries. These are self-dislocating ones. They're very low in trauma, volume of trauma, and they are lax on both sides. So the cartilage doesn't argue with the glenoid often. So it's very unusual to see. The arthritis that you see in MDI is usually after surgical intervention, like radiofrequency, like like capsular plication. And so it's usually iatrogenic, if not any other reason.
If there are no questions, can we ask the second speaker to go ahead? I think sure. Ashish is going to talk now.
Yes.
Yes.
Role of arthroscopy in young arthritic. I remember Ashish does not require interaction here. He's one of the shining stars and who has led with Sanjay, Desai, a lot of the shoulder. They are the fathers of shoulder surgery in India. And after our Calcutta doctor Saha, I know Suvananda may not.
Thank you.
Professor Saha was the father figure in shoulder biomechanics.
Yes. First report on the paper we had read about this, about transplant, cartilage transplant or humeral hair transplant in Pune by Dr. Ashish Babhulkar, and in a young sportsman. And I know for sure he will also talk about, in this situation, biological arthroplasty.
Thank you, Nicholas. Never had my name mentioned in the same breath as Professor Saha. That's too overwhelming. Great respect for this gentleman. Thank you very much. This again is a very, very complex topic. I don't think it works every time. So we have to pick and choose the cases for arthroscopy in young arthritic. I must warn you, this is not a solution for young arthritis, but it's a good procedure if it is applied to the appropriate individual. This CT scan that you're seeing is of a 20-year-old recurrent dislocator. And this is what happens if we don't pick these up. It's going to go for prolific arthritis because he's just 20 and there's a long road ahead for him. So just to reiterate, you could have de novo arthritis, which is the disease arthritis, that is primary glenohumeral arthritis. Most of my talk is going to be centered on the post-instability arthritis. That is where I think personally the application of arthroscopy is most warranted. Post-surgery arthritis like open surgery or open Laddha, anchor arthropathy, probably an extended indication. Chondrolysis is also a good indication provided it's focal and not diffuse. And then there are other conditions. So we've not talked about bupivacaine related arthritis, and there are papers on that, and I'll touch base with that. So basically we have to, take a treatment choice between rehab, arthroscopy, minimal invasive, and the newer implants, which are the stemless or the surface replacements as such. So most patients, I must say, I would treat with a rehab because these are too young. I don't want to mess around with them, pull them on for a long bit. But these are reserved for mild grade 1, grade 2 arthritis as such. And although the pain relief is excellent with rehab, restoration of function may not be. If this patient is a sporty patient, then he's going to find problems getting back to his sport. Microfracture is an option when we have patients who are very focal, superficial cartilage damage, or unaffording patients who cannot go for some of these fancy, expensive regimes. Autologous cartilage implantation is what we'll deal with today. And then stemless will be covered by Sanjay Desai later. So arthroscopy is considered low morbidity, minimal invasive, looked at as temporizing, that eventually the arthritis will be overwhelming and exceed and then come in. Our results, we have patients between 4 years and 8 years is our longest follow-up that we have done. And it's important to diagnose it preoperatively rather than accidentally diagnose the cartilage loss during index surgery, because that gets embarrassing. Because if you've not planned ahead of time and you do your Bankart repair and then go back and advise the patient post-surgery that you need a cartilage surgery, it means 2 more procedures. So if you can optimize this to the index procedure and graft harvesting, then he just needs one more procedure for the ACI as such. So this is an important decision-making process for the surgeon as such. Whether it's a permanent solution or not, it's less likely. I don't promise him a permanent solution. Capsular plication, as I was alluding to in what I said just now, is not a procedure that's too innocent. But this paper from Hansen attributed 12 of 19 patients who received a bupivacaine intra-articular pump. And so bupivacaine got a bad name. And then, so nowadays, we don't inject any local anesthetic into the joint, although most of these bupivacaine studies surprisingly came in as ropivacaine was introduced. But I don't think any analgesic or any anesthetic is above suspicion into joint. Bioanchors in the past, especially the PGAs, were suspect, and they have had problems with spontaneous chondrolysis. And this is a paper from Boden et al. From 2009 where I've borrowed. He had 3 of 22 cases. There are other case studies which have shown 3 and 2 cases of chondrolysis due to bio-knotless anchors. Again, this is one of my patients. We put in the PGA old anchors. This is about 15 years old, and we've seen chondrolysis in this patient. We've maintained her. She's pain-free completely. She's almost a 13-year follow-up. She's got a reasonable movement, but she doesn't have full function of her arm as yet. Fortunately, I don't see metal anchors nowadays, and we advocate all our fellows not to use metal anchors in the glenohumeral joint. If you're really pushed to cost-saving measures, then use them in the rotator cuff surgery. But these are 4 different patients who've had metal anchors leading to erosion of the head of humerus, and that's not a good idea. So skip metal. We have much better options now. In the past, there were limited options as such. For want of time and for reasons of scientific rigor, I will not talk on interposition arthroplasty. I think it is historical. There are a couple of these papers. These are dated 2006 from Deepak Bhatia. But I have spent time with Chodibir during the time that this paper was being written up. And I know for sure I've seen some of his cases. It was a 50-50, so it's not a reliable procedure to go through, and certainly not a procedure that burns all bridges. So it has over the time lost a lot of shine. So we shall not dwell on that. This is a example of a cardiologist who's 50 years old, recurrent instability, no dislocation, but recurrent instability from playing badminton. And that was going on for about 7 to 8 years till he started getting pain. And you can see on the lateral position, you can see that there's significant cartilage damage only in the anterior 1/3. So this is less likely to compromise his function. But for somebody who's just 50 years old, so at that time, therein we've done a microfracture and harvested graft from his Hill-Sachs area where the cartilage was there. So we consider that. Previously, I used to use the autologous chondrocyte from the knee, but we've moved to the shoulder now. So it becomes a less invasive procedure. We are just restricting the incision to the shoulder as such. And when you do your Bankart repair, you do it in such a way that will cover up a significant part of the defect. So it will reduce the area of the cartilage damage. But since it's eroding inside, he came in later, did a 2nd stage ACI after 8 weeks, after we've done the rehab, restored his function, and then again immobilized for another 6 weeks. These are his follow-up MRIs 1 year after the procedure. And there's a slight blemish there at the site of the cartilage, but it's picked up nicely. He has a full function, he's pain-free, and he's back in sports. This is a much more perilous example from a young 17-year-old badminton champion, and will not go into detailed history, but this was his query alleged slap tear that he underwent. Again, oversized anchors, which were incompletely seated, proud, and you can see here that they have dug in a hole for themselves, and they have completely ruined the head of cartilage in a manner. Because this gentleman continued to play badminton because he was a badminton addict, he had national prospects, and so he was playing on this situation, and then he lost the shape of his humerus. This was one of the most challenging. 2012, I was not sure what to offer him. He's one of our first success stories of where we saw that he completely ruined the cartilage all around. So this was a 50 mm defect, and the challenge was to remove the anchors. And so these were very proud anchors. We've actually used trephines to remove the anchors, which created a bigger defect as such. And then followed with an open procedure. We created a silicone cone to avoid spillage, because this is not like a knee where you can keep the part dependent and pour in the modular construct on this. So here we have the ACI graft, which is put in after 1 month, and we've plastered the entire shoulder down nicely. And this is an MRI 1 year later, and you can see a complete smooth cartilage regeneration. You would have noticed that I have not removed the osteophytes, because removal of osteophytes can cause bleeding. We had that problem previously case, and that can insert itself between the graft and the cartilage and the bone and create a problem with union of the cartilage to the bone. So we've left the cartilage osteophytes in position. This is his follow-up arthroscopy after 2 years, and you'll be surprised with the amount of regeneration of cartilage. This was almost a 95% complete regeneration of cartilage. And that is the advice that you would, if at all want to go and check and do a relook arthroscopy, then you would go after 2 years, not before that. It takes that much time for the whole cartilage to mature. He's our longest 8-year follow-up now, and he's now limited. He's not back into badminton. I have not allowed him, but he's such a sport junkie that he switched to table tennis and started playing well. So he's asymptomatic, but at 8 years, he's slowly coming to wear his graft off. We're monitoring him every year. This is another patient who had arthroscopy with a Bankart tear, complete denudation of cartilage. This fellow was unfolding, so we've just done a microfracture debridement and a Bankart repair for this gentleman. And he's good, he's stable. He's had extensive rehab. It took almost 6.5, 7 months to recover. His terminal movements are still restricted. His pain is absent now, but he doesn't have full function to play sport. He's been allowed not to play sport. He does have occasional periods of stiffness in between. So he's not bang normal, but this is a one-time procedure of a debridement and a repair. As I said, this procedure will not be applicable to those who are post-infection or post-putiplat where you have diffuse arthritis. This is probably okay for focal lesions as such. And if there's infection, then the ACI is absolutely ruled out. It cannot be done. So we must know our limitations. It has excellent pain relief. Certainly never tried it for any of the primary OA patients, because that's too diffuse. Primary OA is a disease, so is avascular necrosis. So also, I've been loath to do it in patients who have arthritis after proximal humerus fractures or glenoid fractures. So we've limited largely to post-instability cartilage lesions. I don't know how long the results will last. I never promised them that this is a permanent solution, but at least it buys them time. And even if it lasts for 8 to 10 years, we've given precious time to allow for us to go in for the next level of intervention. You do need to plan it well on the MRIs pre-operatively, because it's embarrassing to offer them 3 different surgeries. So we usually pick this up on the pre-op MRI and plan it on the first index surgery itself as such. So go in early, low morbidity. It's never perfect, but at the same time, best to worship cartilage, do a good surgery, limited radio frequency, and not to use metal anchors as such. Thank you very much for your patient listening.
Thank you, Ashish. Wonderful talk.
Thank you, Ashish. As usual, always to the point and always informative. Can I ask you some questions?
Yes, please. Go ahead.
On biological reconstruction of the glenoid surface using fascia lata, because last Sunday there was a meeting of the BOS and there was a case, and one of the faculty said you should use a fascia lata for that. And do you have any second one? Do you have any experience of using allograft from plafond and from humerus for arthritis of the shoulder, young arthritis?
Right, Nicholas, to take your first question first, in 2006, when I was with Joe DeBeer, we saw a lot of these interposition arthroplasties, and they've used everything else, right from amniotic membrane, IT band, and then he later switched to a synthetic membrane as an interposition. And we saw some okay results, and we saw some disasters, and we saw some infections. So that graph there doesn't work to give them a solution, number one. And if it remains as a nidus and if it gets infected, we've pretty much burnt all bridges and ruled out any further options. So I've been loath to doing all this. I have checked with John Tokish and Joe DeBeer, who probably had some of the largest series, and they are very iffy on the role of this. So no experience on that. As for your second question, I have used osteochondral allografts, but not for arthritis, because that's different. We've used them for large Hill-Sachs lesions in epileptics, where we have 1/3 of the head of humerus has gone off. And they've done well. We have some 7-9 year follow-ups on those. So they seem to do well, but not for focal lesions, I'm afraid.
Ashish, for your cases, did you do ACI only on the humeral head or also on the glenoid defect as well?
So the first case you saw was on the glenoid side, the cardiologist, 50-year-old. So I showed you a case of that. And the second young boy was on the humeral side. So we have equal number of cases for both.
What is your take? Usually these lesions end up with a bipolar lesion. So even if you do one side, the other side would regrow itself, or how does that happen?
So actually, all the patients that we have done, all the 12 have been one-sided lesions. We've not handled bipolar lesions, where that means it's coming too late. Okay. The lesion always starts on one side. When it starts on one side and you go in early, you nip it in the bud. If it has started on the humeral side and it has moved to the glenoid side, then the disease has started. If you see subchondral lesions on the MRI, you're pretty much late. So we are talking about grade 3, grade 4 lesions without subchondral erosion. So on your MRI, we do 3 Tesla MRIs. You see defects in the glenoid, then I'm afraid that disease has gone further ahead. The graft will be wasted. This is expensive procedure. You're doing 2 surgeries together. So you want to give them a fair. And you'll be surprised the amount of regeneration we've achieved. All of them have had MRIs at 18 months or 24 months, and they've grown back the cartilage beautifully. We just have to keep watching. But the indications are absolutely select. You have to be very hard and strict on what you choose.
Ashish, is there a particular way of allowing that the ACI sits only on the humerus and doesn't go on the glenoid? How do you do that? Yeah. Can you just give us an idea?
Very smart question, Nicholas. Because as I said, on the knee, you can make it dependent and get your graft because it's like a gel. So on the humerus, what we've done is we've done open procedures and we have a silicone cup designed to go around and then allow it to set. It sets within 1 minute. On the glenoid, we've been a little brave and adventurous, and we've done it arthroscopically completely in the lateral position, and we do it as a dry scopy. We tried using CO2 insufflation, it doesn't work. So we just stick to a dry scopy. We inject 20 cc of room air and make it dry, and then just proceed quickly.
Can I come in with a question?
Yeah, Nagraj.
Yes, Nagraj.
So Ashish sir, this is related to a young patient who is a gym goer, the ones who are into heavy bench press or heavy push-ups. I have seen in my practice that these people have a diffuse chondral wear, both on the glenoid side and the humeral side. And I have also had the occasion where they have actually come with instability. So you are now in the dilemma of treating them for instability, which is going to tighten them. And this capsulorrhaphy is going to worsen them. So what I've done is skillfully neglecting the chondral wear and just doing a limited kind of a labroplasty, a minimal repair, and making sure that post-op they are mobilized extremely fast. So far, so good. Could you touch on this topic, please?
Nagraj, this is like the Heisenberg complex. It's difficult. I don't have a solution for this condition. There are patients, I have lots of wrestlers who come in late and they're like this. And their biceps is in tatters and the cartilage on both sides is gone off. And I'm very loath to do that for 2 reasons. That number one, I can't give a consistent answer. Some patients do brilliant and some just are so stiff that I can't predict. Number 2, these guys, their brains are in their knees. So you tell them don't play, don't go to gym. They will tell you everything and they'll go straight back to playing as such. So even this young guy who's a badminton player, is impossible to keep them away from sports. So I've been a little reluctant on offering surgery to these patients. So if I've gone in and accidentally seen that there's a complete diffuse cartilage loss, then I just come out, not do anything, and we start exercises within two weeks or so and treat them without an intervention. I try to keep the scarring down, keep the implants down, has been my end. But I don't think you are doing anything wrong or I am doing anything wrong. Both of us have our own different ways to address this complex issue.
I've seen Brian Cole. I think Ashish, if you would,
yes,
he would do limited fixation like Nagraj said, and after the surgery, he would do dry the shoulder joint and do a bone marrow injection directly in the joint. to take care of. So does the DMAC work if we just inject it into the joint?
It was a very tempting solution because most of our patients, we lost almost 4 patients because they were reluctant for 2 procedures. So we thought BMAC is a good thing. We did a lot of work up on the BMAC, and I did some research, and there's absolutely nothing on the literature in favor of BMAC. All the literature that's published is company sponsored. So it's difficult to imagine that. And with so much success, which is proven with the 2-stage procedure, I am again reluctant to rock the boat right now. But if any of you have had any experience with BMAC where one procedure works, I'm very skeptical about bone marrow aspirates working like this. We spoke to John Tokish on this, and he gave me a very confident answer. Told me, if you're not going to quote me, I said, it's BS.
Quoted him.
May I ask one?
Yeah, please.
Yes, please. Mukesh.
Sir, what's your, when do you decide now this guy needs intervention? Only when you do on scope or clinical symptoms other than instability to go in? And second, any role you try to give any intra-articular steroid or any viscose supplementation as a first stage, and then see whether they really need the surgery later on.
Right. These are all instability patients who need fixation. Their cartilage focal damage is secondary to instability. So number one, that instability has to be fixed. It's like ACL with a meniscal problem. So no point doing the meniscus, you have to fix the ACL. So they all come in for an arthroscopy. Fortunately, we pick it up well. The 3 Tesla MRIs pick it up beautifully. 1.5, 1 Tesla MRIs can miss cartilage lesions big time. And X-rays will not show this at all. So once you know for sure this is, then you offer them procedure. I give them a choice that we need not treat your cartilage. We will treat your instability. You've come to me for dislocation. I will solve that problem. But you'll face with the problem, your recovery will be late and blah, blah. So some of them agree, some of them don't agree. So in which case we just do the instability surgery. I have no faith in viscose supplementation. You can catch me. If you ever find me giving viscose supplementation, I'll have to retire that day. So no faith in that. Steroids, again, it depends. If you have an inflammatory component, the steroids will work. Steroids can by themselves create cartilage degeneration. So I don't put steroids for all these surgery patients. If they become stiff post-surgery and I have not done a cartilage implantation, then I have offered steroids to some of these stiff patients.
Yes, sir, sometime after removing this metal anchor, you have a huge bone loss there on the glenoid side. And once it was around 30 to 35% like that. So how do you address those cases?
So as long as you are superficial, the ACI works beautiful for this. Glenoid is like patella, so you have to be very careful. Only focal bone losses will work. Non-contained, diffuse cartilage losses don't respond to ACI at all. And I have no idea, no experience with doing cartilage allograft on the glenoid side. There are some published literature on the humeral side. So you have to be very conservative when you deal with removing. Hopefully we'll get over this problem when everybody stops doing metal anchors on the glenoid side.
I think Ashish, the message that you given to all these whoever listening, the metal anchor should never be put inside for the instability scenario. This is every time we are meeting in the big meetings, we are stressing upon this topic that metal anchor for instability is never, never, and never.
Absolutely. Absolutely.
May I ask, is that metal anchor an issue or is a faulty technique by surgeon which is causing that problem?
No, Mukesh, the metal anchor
even
is
after
issue.
After lysis, sometimes it protrudes. So initially
Yes.
it was in, we have done it, and after 1 year we saw that it's coming back. So that is the main reason. And sometimes it was quite inside the glenoid, and with lysis it comes out.
You must have done so many metal anchors before the other anchors came in.
Yes.
What percentage of your patients had this kind of issues? Cartilage loss?
I have not had a single patient from me, but we have seen anchors sometimes when intraoperatively you drilled well, tapped well, put it in, and it went halfway through. And then it's impossible. On a plastic anchor, you can knock it off, you can use a shaver, you can use a burr and burr it down. So in those 2 instances, we actually removed the metal anchor there in itself. Never leave it in there. So that's, you want to nip it in the bud and just ensure that it doesn't go into a failure mode later on. Got it. So the metal itself is not warranted in the glenoid ever, and we have very good options now. So there's no role for metal at all. Previously, it was an unmet need because there's no other anchor.
Yes, Ashish, I think we are all stressing upon in different shoulder meetings that we have for the instability better to use the suture anchors.
Yes,
because even the bio anchors, they are also creating problem because the osteolysis around the bio anchors is too much. We have used everything, but categorically once the suture anchor came into the market, probably I stopped using all the bios and all the metals.
But
well, I'm not sure on that.
So I think peak is still better.
Peak is inert, absolutely. And the percentage of condylolysis with the newer generation PLLAs is not too bad, but it can always be there. But the whole theme and take-home message from my talk is worship the cartilage. So avoid radiofrequency as best as you can, and avoid injecting bupivacaine, avoid metal anchors. I don't think we'll face this problem, at least for post-instability arthritis.
Thank you, Ashish. This was a really excellent lecture. And even I was really just learned many things from your this topic. Thank you, Ashish.
Thank you. My pleasure.
So, I think Nicholas sir, we can go ahead with the third one.
Can we invite Dr. Mukesh Laddha now to give his talk?
Yes, sir. Is my screen visible?
Yes, Mukesh.
Yes.
Am I audible?
Yeah.
You are.
After a wonderful talk of preserving the shoulder, high task is given to me about replacing the shoulder in young adults, which is a very difficult task. And let me thank Indian Orthopaedic Association, IAS-MOA and Bombay Orthopaedic Society for asking me to share the platform with the all stalwarts. So let me start with this X-ray. A 52-year-old gentleman came to me with bilateral shoulder pain and very mild symptoms, but the X-rays were extremely horrendous and bad looking. No acromiohumeral space, completely gone. So it's a rotator cuff arthropathy bilaterally in 52-year-old gentleman. And even the MRI said everything. But look at his symptoms. He is waving to you and saying, "Doc, please don't touch my shoulder. I am happy," and asking you don't to do anything. I think shoulder is one of the joint which is a very versatile joint in the body, and it adapts to the body very well, or individual can make some adjustment with the shoulder even if it's arthritic or bad looking X-rays. So always try to learn and solve the problem of the patient rather than solving and looking at the X-rays. So young arthritic shoulders, as mentioned by Dr. Abhijeet and Dr. Ashish sir also, it's a very challenging and demanding for all shoulder surgeons like us to deal with, because they have high expectations and they have high demand of their arm. And the underlying anatomy is really not normal, like we have above 50 years of patient because of associated dysplasia, post-operative, post-traumatic, associated implants in it, inflammatory arthropathy, capsulography arthropathy. So the anatomy is also complex. And if we plan to do anything like cartilage, what Dr. Ashish has told, or replacement, then the question comes about longevity and durability of that procedure. So early the surgery, we are inviting the complications also, and the functions may deteriorate with time because of their high demand and high use of the shoulder. So in any younger patient, if you are asking for any arthroplasty, make it clear to them that revision surgery is inevitable and that may come down the line 10 years, 15 years after the primary index procedure. What are the indications as clearly mentioned by Dr. Abhijeet? Chondrolysis, osteonecrosis, instability, capsulography, unreduced posterior dislocations, inflammatory arthritis, osteoarthritis, post-traumatic and infective. These are all the indications. A nice article in 2010 comparing the etiology in the patients under 50 years and above 50 years. Above 50 years, it's very clear the majority chunk is degenerative joint disease, but below 50 years, the chunk is not only one. Patient do have maximum number of capsulography arthropathy, degenerative, inflammatory arthritis, rheumatoid, post-traumatic and avian. This forms the main chunk. So you are dealing with altogether different etiology in under 50 and above 50. So one should keep this in mind if they are dealing with a young arthritic shoulder. So the decision making in young arthritic shoulder should be multifactorial depending on patient specific and defect specific. As far as patient is concerned, what is his age, what are his symptoms, prior treatment, and what are his demands. And as a surgeon, will I be able to match his demand? And depending upon the defect, the location, the size and depth of the defect, the containment of the defect, and the overall geometry, unipolar or bipolar lesion. So the various options to treat young arthritic shoulder, conservative still holds a major chunk for the treatment. Arthroscopic debridement, cartilage regeneration, replacement in form of hemiarthroplasty, total shoulder, reverse shoulder, and last is arthrodesis. So I'll restrict my talk to the replacement part of in young arthritic shoulder. Hemiarthroplasty and total shoulder arthroplasty plays a major chunk. Hemiarthroplasty can be resurfacing, stemless hemi, standard stemmed hemiarthroplasty. And on the glenoid side, you may have rim and run technique and biological interposition. But as a surgeon, we should always think about arthritic conditions in young active patient, and we should question ourselves before we jump into arthroplasty, how can I manage this cartilage loss without arthroplasty? So this is a young female, 44-year female who had a pain in shoulder since 8 to 10 years of duration, and now it's a significant restriction of the movements, and you can see huge amount of osteophyte formation. And as a protocol, every shoulder replacement, if you are planning, the patient should undergo MRI, CT scan to know the amount of glenoid bone loss and classify it whether it is type A, B1, B2 or type C glenoid and associated humeral bone loss, and also to notice the condition of rotator cuff, because the success of Hemi or total shoulder depends on how good is the rotator cuff. I went ahead and did here a standard stemmed hemiarthroplasty with a rim and run technique on the glenoid side. So the hemiarthroplasty should be, the hemi shoulder should be a modular one, because the humeral head doesn't sit in the center of the shaft. It should have an offset of posterior medial offset. The humeral height should match, and even the diameter of the humeral head should match the native humeral head. And you should repair the rotator cuff well. This is only 4 months down the line. Patient is trying to recover with physiotherapy. She had complete pain relief, but still stiffness is there, and she is undergoing rehab. So what is rim and run technique popularized by Matson? It has anatomical and biological basis. Anatomical basis that it should have a concentric conservative glenoid rimming to match the humeral head, and biological aspect is that it will regenerate fibrocartilage in response to early motion of prosthetic head versus subchondral glenoid surface. It has a good results in patient younger than 55 years of age, but be careful or try to avoid this rim and run technique in patients having inflammatory arthritis, those who are smokers, non-compliance to rehab, patient on narcotics and depression. So the primary indication of rim and run technique will be post-traumatic arthritis and primary osteoarthritis in young individual. A 30-year-old female with a severe degenerative arthritis, mostly an inflammatory type, the amount of glenoid bone loss she had and the type of pain she had, she was unable to do her activities of even daily living. She was too young to do anything. So I did her primary shoulder arthroplasty, hemiarthroplasty, and did nothing to the glenoid. And unfortunately, I don't have an X-ray, but this has a recent 5 years down the line clinical picture. Nearly full movements, painless, and able to do her all activities with hemiarthroplasty. So shoulder hemiarthroplasty or total shoulder, does it work in younger patient with rheumatoid arthritis? Yes. Total shoulder arthroplasty had improved pain relief and improved range of motion compared to hemiarthroplasty, but for both, the rotator cuff should be intact. 24-year female collapsed secondary to sickle cell disease. She is a sickle cell disease who had already undergone one side THR 4 years ago, and the pain in the shoulder was even before she had developed hip problem. But as I told, shoulder adjusts the body, but now the pain and stiffness was too much for her. And then the patient told, doc, do something to my shoulder also. And being young, I just did classical stemmed hemi shoulder replacement and microfracture on the glenoid because it was a focal chondral damage. And she is 2 years post-op. She still have restricted movements, but absolutely pain-free. The rotations are also there, and she is able to manage her all activities of daily living. So shoulder arthroplasty under 55 years of age do work well, and the results and literature favor that total shoulder arthroplasty have more pain relief and good movements. but worried about the glenoid loosening on one side in total shoulder arthroplasty, and on the other side in the Hemi, there are chances of glenoid erosion and deteriorating of the function in the late course of the disease. As mentioned by Dr. Babhulkar sir, interpositional arthroplasty has also given way here. A lot of literature says interpositional arthroplasty doesn't work well, except Broch Krishnan, who had shown that in 10 to 15 years result using tendo achilis, he had some good to very good results. I personally don't have any experience with interpositional arthroplasty along with Hemi shoulder. As mentioned, and everyone agrees that metal anchor should not be used because this leads to complete disaster in the cartilage. And here the patient have both humeral head as well as the glenoid problem. So this patient, having surgery done some 8 years back, came with severe pain and stiffness because of associated arthritis and that metal anchor popping out, but had a good rotator cuff. So went ahead and did stemless Hemi. In this, the details will be taken care by Dr. Desai in next lecture. And this also do very well. So Hemi arthroplasty in a young chap with a bipolar lesion with minimum glenoid loss, you can see 3 years post-operative, he is having full movements, good external rotation, abduction, forward elevation, and even is doing circumduction. But beware and always tell these patients that this is not a definitive surgery, so use your shoulder with caution, otherwise the chances of implant failure will be soon. So long-term or mid to long-term results of total shoulder arthroplasty, a good article in Journal of Shoulder and Elbow Surgery in 2013. Down the line 10 years, the glenoid loosening rate is 38%. So this is really scary because glenoid is a very small bone. And if anything goes wrong with your glenoid component, there will be significant glenoid bone loss in early age. And then reconstructing that glenoid bone loss is a tough job. So personally, I prefer to do Hemi replacement along with rim and run technique or microfracture in the glenoid. This is another patient with a chronic unreduced posterior lock dislocations of 8 to 9 months of duration. And there was a significant amount of humeral head bone loss. I tried to preserve this with the help of modified McLaughlin's procedure, but on table it was dislocating again, and went ahead and did routine primary stemmed Hemi shoulder replacement. And that's the gentleman who owns a dhaba and a poultry farm, able to do all activities down the line. It's 2 years down the line, is pain-free and do all activities needed in his life. This is one of the nice article which shows 20 years follow-up of both total shoulder and Hemi shoulder replacement. And they say the long-term follow-up in both continue to provide lasting pain relief and improved range of motion. However, there are a large number of unsatisfactory need rating, whereas both the group have survivorship in excess of 75% at 20 years. So it's a surgeon and he should be very cautious in performing shoulder arthroplasty in younger patient. This a young lady with very severe rheumatoid arthritis already underwent bilateral total hip and bilateral total knee replacement, came to me with a severe shoulder pain, not able to do her daily routines, severe stiffness and pain. And as you see, the CT scan showed a significant amount of glenoid bone loss. And on MRI, you can see though the cuff was intact, but looks to be dysfunctional because of significant amount of fatty infiltration and low demand patient. So I went ahead and did reverse shoulder arthroplasty using an augmented metaglene so that I can properly place my glenosphere in the proper position, and did primary reverse shoulder arthroplasty in this patient. She is 2 years down the line and had a good range of motion, near complete forward elevation, abduction, external rotation, and internal rotation. In literature, reverse shoulder below 65, they said they do good even in presence of cuff deficient shoulder or failed arthropathy. And the complication and revision rates were comparable to those when we do reverse shoulder in older population. So in conclusion, Hemi is an easy procedure, less operating time, less risk of instability, reliable pain relief, bone conserving, and with the newer stemless implants or resurfacing, it's really bone preserving. Reasonably, patient have good functions and can be converted to total shoulder arthroplasty when and where needed. On the downside, it has progressive glenoid erosion in the due course of time with deteriorating results and residual stiffness. On the other side, total shoulder is more consistent with pain relief and better function, but a difficult procedure, longer operating time, polywear and loosening round line 10 years is a major concern, and that may lead to more glenoid bone loss. Reverse shoulder in a very selected cases we have to do. So thank you, and see that you treat the patient clinically and not the X-ray and MRI. And always ask this question before you intervene: how can I manage cartilage loss without arthroplasty? Thank you.
Thank you, Mukesh. Thank you, Mukesh. As usual, it was delightful.
Tailor-made treatment for the patient. It's called a tailor-made treatment for the patient.
Yes, sir.
To devise the treatment for the patient and his symptoms. Are you using the same processes in all patients, or you have a different type? And in one case, you have shown stemless. How do you decide all that?
So in Nagpur, initially there was no availability of implants, so only Evolutus company was there. So I have used their stemmed implants in initial patients. But with the advent of stemless Hemi, if I have good amount of metaphyseal bone, I will definitely go for stemless Hemi.
And what is the opinion of the faculty when you have an inflammatory arthritis which affects both the glenoid as well as the head, to use only a Hemi replacement procedure?
No, I think Nicholas sir, then it's a really problematic scenario. Because if your glenoid is already been eroded and is an inflammatory scenario, probably Ashish will also agree that you have to go with both side one. Otherwise, this Hemi is not going to succeed for a long period of time. Ashish?
Yes, Nicholas, again, a very contentious problem, but you made it easy. In an inflammatory, I have no hesitation. I would always do a total shoulder on those.
Yes.
The same question asked 10 years back. We didn't have a good glenoid. These were Kale glenoids and they were poly and they were not the best. But now we have some of the best implants, so I have no hesitation. So 10 years back, we've done some Hemis and we are doing now 15 and 16-year follow-ups. They're good. They have a very good range of movement. They are pain-free, but they're eroding the glenoid. And so their glenoid vault has medialized. So eventually when they fail, I'm going to have a big challenge to build up that glenoid. So it's not going to be a plain revision. They will need a bio-RSA or something like that. So do be careful on doing individual Hemi. Even literature will tell you that the pain relief with a total is far superior to the Hemi.
Yes.
Agreed. But in patients with inflammatory arthritis, by the time they come to you, they have significant glenoid loss. So doing a stemmed or cemented poly with a bone graft, how difficult is that? Because you don't have a metal bag to put something on the glenoid in total shoulder.
Can we ask Sanjay's opinion?
Yeah, so even in inflammatory arthropathy, if the patient is young, I will do a Hemi. I will not replace the glenoid. And if the condition of the humeral head is not badly collapsed, on several occasions, I have done a surface replacement. And they have done very well. Because my main concern is that 10, 12 years down the line, is it easier to replace a plastic glenoid with cavitation in the bone, a loose plastic glenoid with cavitation, or is it easier to revise a eroded medialized glenoid? And I think it's a very simple answer. I'll show you some examples in my talk where I have now replaced the surface, I think 10, 12 years, having done 10, 12 years ago. And it was really very simple and straightforward, not only to replace revise the humeral surface replacement, but also to do the glenoid. And I'll show you that one example in my talk. So age is the most important criteria. I'm okay even if it is an inflammatory arthropathy.
That means you must also tell the patient that you might require another operation at the end of 10 years, is it?
Yes, that is, Nicholas, that is going, you'll have to tell that even if you did a total.
Even if you eat for the total, you have to tell like that.
You'll have to.
Long-term follow-up for 15 years is a still 50-50 match.
No, I will tell you the latest follow-up of glenoid from France, multi-center. More than 50% of glenoid will loosen at 13 years.
Yes.
Which is too high. And this is in all the top centers in France. And imagine revising this glenoid plastic, which is loose, bone cavitation, bone all eaten up, and then to do whichever arthroplasty you want to do. It's going to be a very tough challenge as compared to a medialized eburnated glenoid, which has not been replaced.
Yes, Mukesh, another one thing, probably somebody was asking about the metal back glenoid. Even that is coming in the market.
Yeah, we do have
that is for the revision scenario, but that will be too great for this discussion because we'll be deviating from the main track. I think we should be happy with what Sanjay and Ashish told us.
But only one comment, I agree with some of the slides which Dr. Laddha showed from Nagpur. My prediction is that hemi arthroplasty will come back in a big way in the coming decade.
Thank you. Let's see.
Ashish, there was a question by Dr. Maheshwari on chat box. We just missed it once your presentation ended. He says, what is the role of debridement and microfracture in osteoarthritis shoulder? Can it work as a time buying option? Do you do arthroscopy in the primary OA? And if at all, do you do a microfracture and does it help?
So my entire talk, the caveat was that I will not do arthroscopy in primary glenohumeral arthritis because that is a disease. What I dealt with arthroscopy were focal lesions. So even if those focal lesions are 50 mm, it is still, the disease is difficult to treat with this thing. We have treated several with a conservative rehab program and they're happy, they're pain-free, they're maintaining. But once you put your scope in, then the onus is on you because they tend to deteriorate very rapidly after any surgical procedure, unless it's an arthroplasty as such.
Ashish and Sanjay, do you all ever do rim and run procedure, and in what situations?
I think Mukesh covered that very well, that when you're doing only hemi arthroplasties and young patients, then rather than mess around with the glenoid, you can just reshape it. There's a limitation of how much rim and run you can do. So for 10-degree versions is what I would restrict my rim and runs to.
Nicholas, to answer your question, every single surface or hemi that I have done, I have dealt with the glenoid as if I'm going to replace it, which means a complete capsulotomy, as if I'm going to replace it, though I know I'm not replacing it, and then multiple drill holes into the subchondral bone in every single hemi. Not rim and run, but this is what I do.
What does this additional technique does it for you?
I think it's a very good pain relief method. More than me, the Reading group has a huge experience of more than 35 years. And almost 80% of their arthroplasties today are still surface hemis.
Yes, now Sanjay, this is now the rim and run is well accepted throughout the world now.
No. It's a big controversial thing.
Yes, controversial. Now some people are doing still. Now people are doing this.
Some people are doing, but there is a big debate whether it works or not. It's not.
This debate
very limited indication. Very limited.
Yeah.
Ramanendu, you said it's controversial, so everybody will not do it. Only some people will do.
Yeah, some people are now people are advocating that you have to go with the rim and run. Probably after 10 years we might be sitting together. They will give a perfect comment whether to how to go ahead.
Dr. Desai and
let's move to the next topic.
I think Mukesh, we should move to the next topic. Otherwise, we'll be trying.
Can I share my screen?
Mukesh, last question.
So rim and run and microfracture ultimately both will form fibrocartilage on the glenoid. So any experience of both of you, whether we should do this or we should do that?
Mukesh, different indications. Microfracture is for these partial focal cartilage lesions.
I agree.
The rim and run is essentially for a retroverted glenoid, because if you have a 10 degrees retroverted glenoid and you do a standard hemi, then the articulation is going to be skewed and it will fail faster and it will go into a rocking horse phenomena. So you want to reposition the glenoid to match congruency with these things. So different indications for both.
Okay.
Yes, Sanjay.
Let's start with Sanjay. Let's get Sanjay going with his next talk.
Join.
I think, is anybody sharing? I need to share, so.
No,
Go ahead.
nobody's sharing. Go
No
ahead.
one is sharing.
Yes, coming. Yeah.
Can you see my slides?
Yeah.
Yes.
Okay.
Fine.
So at the outset, I must thank Indian Arthroscopy Society, Bombay Orthopaedic Society, Maharashtra, and Indian Orthopaedic Association. Thank you very much. And I have slightly modified Ashish's definition of young arthritic. He said below 50, but that kind of, I feel offended. So below 60, Ashish, if you don't mind. So now I think when you're dealing with young arthritic shoulder, and I take it up from a point where Ashish and others have already presented before embarking on arthroplasty, what all you do, conservative treatment, that was a very nice talk, and then microfracture or ACI or interposition, all that is done, and now the patient is ready for an arthroplasty. I take it from there. Now, when you're dealing with a relatively young patient, I think the two factors which are bearing a very heavy load on my mind. One is these patients have a high functional demand. I have some golfers with me who need, and they are in their early or mid 50s. And the second point is that very high chance that these patients will need a second surgery. So these are the two very important factors which have a bearing in my decision making as to which arthroplasty and how much of an arthroplasty I will do. So first of all, sorry Mukesh, but stemmed replacement has too many problems. The world has been doing it for more than 40, 50 years. There are problems with the cement, there are problems with the stem, there is problem with the material. We know what happens with the stem prosthesis. Often the cement extrudes. This is one of my own patients. Fortunately, he did not have a radial nerve palsy, but you could have that also. Then it is difficult to use a stem if you have a malunited humerus fracture or if somebody has an elbow replacement. And the most important factor which I have against a stemmed arthroplasty is that it is very difficult to replicate the anatomy. It is surgically demanding. You need a lot of experience, even with the third generation prosthesis, which are the adaptable prosthesis. Why is it difficult? Look at the variation in anatomy. Huge variation. Just concentrate on, let us say, the most common, say, retroversion. See, it can be antiverted 6.7 degrees to retroverted 47 degrees. So it's very difficult to match the anatomy, and which is going to be crucial, especially in a young arthritic patient, because he wants a lot more function than a 75-year-old arthritic patient. We know about this variation in anatomy, and this is what a stemmed arthroplasty, the first and second generation, used to do. Totally non-anatomic. Now, let's look at the history. Why the hell did the stem come into the scene? And if you look at history, you have most of the answers hidden there. How was the shoulder prosthesis designed? It was designed simultaneously on the east coast of United States and in Europe. In Europe, at the Royal National, Ian Bailey and gang, and they designed a shoulder prosthesis primarily for tumors. And if you look at Charles Neer's work on the East Coast, he designed the prosthesis for proximal humerus fractures. This is how the humeral prosthesis was born. And what does history tell you? That the prosthesis was never designed for arthritis. We just incorporated this tumor and fracture prosthesis into arthritis without thinking the world over. So there is no rationale behind the stem. We just copied it. It was easy. What we really need, like knee replacement, is a nice smooth surface which restores the geometry of the normal articular surface. It's the same rationale as the knee replacement. Now, we have a huge a la carte menu when you want to do a shoulder arthroplasty in 2020. I'm going to restrict myself because previous speakers have spoken on stemmed hemi arthroplasty and anatomic total shoulder. I'm going to restrict myself to stemless shoulder arthroplasty. I'm going to give you a bouquet and give you my logic and reasoning, which one I select and why. So the factors which help me decide is age of the patient and the activity level. What is the quality of the proximal humeral bone? And what is the degree of the cartilage wear, particularly on the glenoid, the condition of the rotator cuff, and whether I'm doing it for, in this age group, it is often post-trauma arthritis, as Ashish showed, following instability repair. But in a fair number, it can be a degenerative early onset osteoarthritis. Now, what are we aiming for in a shoulder replacement? You want to replace the exact size and volume. Two things, I repeat, you want to replace the exact size and volume of the humeral head. And in a stem one, it is the stem which dictates a lot of what you do on the head, which is what I don't like. I would love to do a replacement of the exact size and volume of the proximal humeral head, where the stem does not dictate what I want to do, and hence the stemless. We have now multiple sizes to replicate the anatomy to precision, and we have wonderful instrumentation which allows you to replace the exact amount of volume that you osteotomized and orientate the new head exactly in the anatomic position, which covers everything, the retroversion, the offset, all of it with ease, without much difficulty. So my indications are young patients below 75. If I have an arthritic shoulder with a good rotator cuff, these days I do not do a stemless total shoulder replacement. I will do a stemless total shoulder replacement. Whereas in the very young, I still continue to do a surface replacement, which is a Hemi. Now let's see what we have in the market. In the world market, you have in the so-called stemless category, you have the short stem, not available in India, so I won't waste time on that. You have total resurfacing. It is very much available and in use. I've been using it for more than 18 years, I think. You have focal resurfacing. Again, I won't talk. It's not available and very few indications. And then you have the stemless. So my talk is going to concentrate my experience on the resurfacing, which is the cap, and the stemless. So number 2 and number 4. So on this X-ray, the B and the C. So let's skip the stemless. I'm short stem. Why? Because I'm not impressed. It's neither here nor there. Total resurfacing. We all know it started 35 years ago, long, long ago. Huge experience the world has, especially Reading Group. Similar concept to hip resurfacing. Very simple procedure, takes 35-40 minutes. Once you get the hang of it, and now it is even better. It has got hydroxyapatite coating on the undersurface. I've been using it, and I will show you my results, which are already published. It is anatomic, it is bone preserving, short procedure. You don't mess around with the intramedullary reaming, and whether there is a shaft non-union, malunion, or violation doesn't matter. And it is easy to revise. This started in 1979. Can you imagine how many years ago? And what is the best part of this prosthesis? That the primary fundamental design remains unchanged even after 40 years. Copeland data, we all know that 95% survivalship at 10 years. Now you have still a longer follow-up already published by Offer, Levy and gang. This is my paper, midterm result, 57 cases, all were Hemis, all to the glenoid. I did what I just told Nicholas. And I have a 94% constant score at an average of 5 years. Some examples. Here is a male patient, age 58, so young by the revised definition. And this is X-ray 6 years post-op. And this is same patient, 12 years post-op, his function. He's 70 years now from 58. Nearly full forward elevation. He hardly has any pain. And he can touch his dorsolumbar spine. Another patient, 66-year-old, this is 10-year follow-up. I can see a little bit of glenoid erosion, but they do quite well. At 66, he's happy. He's able to do whatever he wishes to do. Another example, what the previous speakers presented, I agree with Samantha's comment that don't use metal anchors. This is a 44-year-old general physician, 7 years post-op, a failed bankard with protruding metal anchors, eroding the glenoid. Now, this was a tricky one because I had all the intentions of removing those metal anchors, but they were so much buried and solidly fitting in, and 4 of them, that I was worried that if I try to be too aggressive, half the glenoid will be in my hand. So I left those anchors and I did a surface replacement, 7 years post-op, so far so good. In summary, minimal bone removal with surface replacement, the least of all the stemless. It's a cementless fixation. Basic concept, design unchanged, not 30 but 40 years. Hydroxyapatite coated prosthesis. And the results equal to a stem prosthesis. Now let's move on. Focal resurfacing, I'm going to skip. Now is the real, the latest, the hottest of these stemless varieties. Now, once it is launched and it shows promise, everybody joins the bandwagon. So these are different company products. I will even tell you that which one is available. We have the Biomet one, which is the TESS. Then we have the Eclipse from Arthritic. And then we have the Zimmer. So we have out of 6, at least 3, and the Evolutus one, 4 available in the Indian market. Zimmer is down in the pipeline. So at least 3 available as of now. Now, a few tips about the stemless. The Just Unique, what I like is, the Unique from Evolutus stemless is there is only one jig which allows you to do everything in one shot. And they have multiple sizes. So it's quite accurate in that sense when you resect the head for a stemless from Evolutus. The TESS, I have little experience, but what I like about the Biomet prosthesis is that they also have a stemless for a reverse, as you can see here. The Zimmer one is not yet in. And then this is the one I use the most, the Arthritic one. I like the fixation of the plate with the cage screw. It's a very clever idea designed by my boss. So I do tend to use it a lot and I'm very comfortable with it. The only thing is the humeral cut requires a little bit of eyeballing. It doesn't have that one jig which can do everything. It has a jig, but there are only 2 sizes. And therefore you need a little bit of experience in making the perfect cut of the humeral head. Some examples. Post-traumatic AVN, a female of 48. The head is almost completely collapsed, in a lot of pain. Of course, the cuff is intact. An ideal case for a Hemi arthroplasty, and I did an Eclipse here. One more example, 45-year-old, similar AVN. This is a Evolutus prosthesis. Again, both Eclipse as well as this are uncemented. Nothing done to the glenoid. 63-year-old osteoarthritis. I'm sorry, Ashish, this is not as young as you would want it to be, but this is just to give you an example that how stemless is. So you see that the glenoid is also quite affected. So in a 63, I did a total shoulder replacement, stemless. One more example of the Nano, the Biomet one, total shoulder and a reverse. So now let me give you the commercial side of it. What is the market like? 57% of the market is going to be stemless. This is data from France 2012. If you look at the Hemi arthroplasties and the resurfacing and the total anatomic, 56 and 57% of all arthroplasties I expect in the coming decade to be stemless arthroplasties. So here is the literature review in one slide for you to see. Go down straight to the TESS, which is the longest follow-up of 7.8 years and a revision rate of around 9.7%. So it does show a lot of promise. 7.8 follow-up is not that long, but it does seem promising for the future. There are some challenges. You can make errors even in the stemless replacement. See that first one is in varus, the glenoid is loose, and that is unstable. So it's not a piece of cake. You have to have enough knowledge and experience, but if you do it correctly, you will have a good result. Common problems are varus cut, overstuffing, and not doing a proper subscapularis repair. So I mentioned in our discussion that I will show you a case. Look at this surface replacement done by me, a Hemi surface replacement. in a male 11 years ago. 11 years ago. And he came to me in 2019, and this is a CT scan showing how well it is firmly fixed even after 11 years. His only complaint was pain, and his cuff was also showing a bit of degeneration. I am not so sure whether the pain was from the glenoid or because of weakened cuff, because the power in the cuff was less. MRI showed, the ultrasound showed that the cuff is thinned out but still intact, but it was weak. So maybe the pain was coming from the cuff and also perhaps from the glenoid. So I went ahead and did a reverse shoulder arthroplasty. He's 68 years old. If this lasts for about 14, 15 years, hopefully he should be through. So my experience, it was very easy to revise that surface replacement. I just had to chop it just under the cap, and it behaved like a virgin shoulder. The glenoid was untouched, so I had no difficulty in putting the metagleen and the glenosphere for a reverse shoulder arthroplasty. This is exactly what I was saying in our discussion, that the revision of stemless is much easier than a stem prosthesis. It's not just me. There are many who think the same. Here is the paper from Holshan 2017. So why should we use stemless implant? One, the humeral implant is positioned independently of the humeral shaft or the stem. This is what I like the most. And the prosthesis can be adjusted perfectly as anatomic as possible. It is easier to revise. And if you had to do a total shoulder, then a stemless where you chop the head, the glenoid view is as good as any other hemiarthroplasty. In conclusion, the question that we should be asking is, what is the indication? Not that what is the indication for stemless or a surface. The question we should ask is, what is now in 2020 the reason or the indication to do a stem prosthesis? Thank you very much.
Thank you, Sanjay. As usual, it was excellent.
Always informative, always excellent and to the point. With a lot of
Thank you very much.
Thank you. Any questions?
So, Dr.
I'd like to make a couple of comments. Sanjay, nice talk, comprehensively covered everything. It is a difficult topic. I don't think we have a perfect solution for the young arthritic. The short-stemmed reverse, I will not name the company, but the stemless reverse has been withdrawn from a couple of countries, including Korea. They have big concerns because there's a lot of deflection of forces. But the total shoulder stemless is the new fashion bug, and it's picking up very fast. And I completely agree with you. It's going to be the future for most of our early OA patients. The other small comment I would like to make is the short stem implants are available in India. The Equinox, which is the exacted stem, is only 50 mm. And so there's no reason in using a 120, 130 mm stem that are conventional. Biomet has a 83 mm stem that's available in India. Their 40 mm stem is not available in India. So
those are not the short, those are not, Ashish, those are not the short stem that the offer levy design one. Like, you know.
No. But these are short stem. Conventional stems are 130. So it's a smart idea to use a 50 or 83 stem. The humerus doesn't need to behave like the total hip replacements. We need a long stem. But conceptually, I think we've got everything correct on this webinar. All the take-home messages are perfect, spot on.
Ashish, Dr. Maheshwari has put a question on the chat box. He says, Sanjay, how do you do a capsulectomy around the glenoid when you are resurfacing? There's just no space to do that.
So it just requires a few good retractors. Jiten, let me tell you, if you're listening, that doing a capsulotomy is not difficult at all. Even when you're doing a surface replacement, there is a trial plastic cap. Once you ream the head, you put the trial plastic cap so that the head is not damaged by your retractor, and you can easily, in fact, the Reading people have done many glenoid replacement with a surface. So if it is possible for them to do a glenoid plastic replacement, then doing a capsulotomy and drilling few holes is not difficult at all. Not an issue. You will have no difficulty knowing your experience.
Dr. Desai,
Yeah.
your
agree with
indication
that,
to do a stem Hemi. Now,
Sorry, I didn't catch it.
what is your indication of doing a stemmed Hemi now?
For some reason, I'm unable to do a stemless. Only then. I'll give you an example.
Yes, sir.
Somebody showed, I think it was you or somebody else, where the head was totally deformed and collapsed like a table tennis ball, which is compressed. I think your case. Yes. It will be difficult to replicate the anatomy for a stemless. That is example one. And
metaphyseal bone, basically.
And the second situation where I have done a stem, it's only because I'm compelled to, is where the bone was so osteoporotic, a rheumatoid patient, that I was nervous that even the Eclipse K screw may not be good enough to hold the prosthesis. So those are the two situations where, in summary, where I'm just unable to do. Otherwise, I will always now do a stem.
One other indication, Mukesh, would be a bad avian. Where the head is deformed, then that's an ideal indication for a stem.
So Ashish, if there is a progression of avian which might happen and you have already done a surface replacement and over a period of time the subchondral bone becomes bad, are there chances of these surface replacements getting loose in an avian case?
Yes, you are right. If you compare stemless replacements or surface replacements, OA versus avian, the failure rate in avian is higher. But a smart surgeon will always wait for the avian to mature, harden up, then it becomes sclerotic bone. So you have to give enough time for the whole thing to mature up.
And in cases in avian, if you are doing and you have some kind of cystic formation or cyst seen in the head area, metaphyseal area, do you still progress would do Eclipse or would you actually shift to a stemmed Hemi?
If you have an eccentric affection, then it will affect the stability of that prosthesis. If you have a small central one where a screwed implant is going to get a good grip into the distal cortex, then that's not a problem.
Sanjay, the one thing I just want to learn from you, how to prevent that overstuffing, because we are all concerned about the overstuffing of the Hemi. What's your guru mantra on that?
No. See, if you had to make an error, understuff by a millimeter, but don't overstuff. As simple as that. Don't when you cut the humeral head. Are you talking about, say, stemless arthroplasty?
Yes.
You chop the humeral head. Now, the diameter is quite healthy and virgin to rely upon, even in an avian. After you cut the osteotomized part of the proximal humerus, once you check the diameter, now you have to decide on the thickness. So diameter, you will not make an error. You will put a trial plate and see it has a cortical fit. And once you are sure about the cortical fit diameter, say it is 44. Now you have only two thickness to choose from. So if you are not sure, select the 16 instead of 18 mm.
Okay.
You know what I'm saying?
No,
or on the smaller side.
Understood.
Yeah. Question for both Dr. Desai and Babhulkar, sir. As Dr. Desai told, case resurfacing will help you to get exact version and other things. But with the modular stem, if you do a stemmed Hemi, the head is very modular. You can shift it in either direction, superior, inferior, medial, lateral, and get that exact version as well as all the other things.
It has got 9 permutations here.
Is there any literature mentioning the error is more in stemmed Hemi as far as version and the height of the prosthesis is concerned, and it is less with the resurfacing? Means I didn't came across to it.
No, I think there is. I don't recall, and it is from Reading. But leave aside the published literature. If you do surface, you will realize.
I agree. I started doing it.
That there is very little scope for
error.
Error in, let me tell you, error in retroversion and offset. The only error I'll tell you might make is in varus valgus.
Agree.
You have
okay.
Yeah.
Mukesh, one sec. I think that was a very smart question to ask. But let me make a point. Your restoration of version is not dependent on the prosthesis. It's your cut.
Yes.
And most surgeons will take a predetermined 30 degrees version cut. You have decided the version on the cut. and then you are trying to adjust it on the prosthesis. You understand? With a good stemless, which has a good jig, not all of them have it, but if a good reliable jig, you are minimizing that and retaining the proximal humerus version. So all you're doing, and that was the beauty of the surface replacement, which came in earlier, which has become defunct now, is you're not messing around with the native version at all. So you can't go wrong. There's a big difference in what you said and what is done. So understand the concept that the stemless, you are not messing around with proximal humerus anatomy, which with your total shoulder or hemi arthroplasty, you're taking the proximal head off completely. And if you have taken the wrong cut, then whatever you do, you cannot substitute that with an implant.
So resurfacing and stemless hemi are total different things.
Yes, resurfacing, you have not taken a cut. You have just milled the bone around that. So that is even better, but its survival has not been good. The design hasn't been good. It may make a comeback again.
Okay.
You understand? So let's understand that whatever we do in replacement, we cannot do what nature has done.
Agreed.
And the surgeon who's able to restore the native anatomy as close as possible will get an excellent result. The one who doesn't will not get an excellent.
Agreed.
Yeah. I think that was an excellent message from Sanjay, that nowadays people are more towards the stemless one. So I think, Ashish, we can move ahead with Nagraj.
Yes, please.
Okay, so I'll start sharing my screen.
Yeah, Nagraj, it is coming.
So thank you, Dr. Ashish, for giving me this opportunity. Bombay Orthopaedic Society, Indian Arthroscopy Society, and Indian Orthopaedic Association. Most of the slides which have been in my presentation have been already covered, and this is going to be more of a reinforcement of some of the thought processes that has been discussed by the stalwarts. This is my profile. A quick mention about the age factor, which Desai sir also mentioned. It's a very empirical way to call a young patient as somebody who's less than 50 years. It could be somebody who's less than 55 or less than 60. But why is it important to know who is actually a young patient? It's not exactly the gestational or the chronological age. This was the article which basically labeled as a young patient for shoulder arthroplasty as someone less than 55 years. And probably that has been followed in the ensuing papers. But what's important is the data which basically was taken from the total hip arthroplasty authors, is that younger the patient, higher will be his activity level. Obviously, he will have higher expectations from his arthroplasty procedure. Therefore, more important than the chronological age is the physiologic age, his activity level, what are the comorbidities which are contributing to his bone weaknesses, his expectations after arthroplasty. So therefore, more than age, what's important is whether this patient that we are dealing with, is he a low demand or a high demand? So we could have a high demand 60-year-old or a very low demand 50-year-old. So that's what we are looking at. From the other paper which came from Hospital for Special Surgery, they mentioned that young age was the only important predictor of having increased expectations, because they were wanting to have ability to exercise, participate in sports, and that was the most important criterion for the patient to rate his shoulder as a successful replaced shoulder. So whether it is the senior authors here or the youngsters that we are here, what are the challenges for us for a young patient in shoulder replacement is that they have more number of years of life remaining, which will definitely need a revision in his lifetime. They have got higher activity expectations. They want better functional outcomes because they want to do sports. All this is going to cause increased stress and wear of the prosthetic components. The combination of the patient expectations and the available literature is probably the only thing that we have in choosing the best procedure for the patient. So let me repeat, understanding that the patient expectations, not his age, and the available literature is probably the only thing that helps us to choose the best procedure for the patient. And that's my job in this presentation, to give you the best in the literature that's available. As in the words of the godfather of...
Sir, हम लोग एक next week quad spine पे consensus meeting कर रहे हैं. Yes, Friday को plan कर रहे हैं. तो सर Friday को आपका कितने बजे तक free हो जाता है सर UCM
I think we have to mute.
Rajiv, please.
तो evening में रखेंगे सर या फिर ये थोड़ा क्योंकि उसी समय आजकल ज़्यादा लोग
रहते हैं. Somehow mute him. Please,
Dr. Samanta, आपको host
around 6 o'clock से start करते हैं, 6 or 7 o'clock, क्योंकि अभी ज़्यादातर लोग सर फिर back to अभी काम पे लौट आए हैं, तो फिर 6-7 बजे तक लोग घर लौट आ रहे हैं.
Yeah.
Yes, done.
Yeah, Nagraj, sorry, you
okay, go ahead.
No problem. So, in the words of the godfather of shoulder surgery, Charlie Neer, way back in 1990, he has mentioned exactly what Dr. Babhulkar mentioned, that the design of the prosthesis should basically mimic the normal anatomy of the patient. If the surgeon follows this principle, there will be the best function and the highest durability. So this is what we typically know, that glenohumeral osteoarthritis, whether it's in the elderly, above 60, 65, or in the younger patients, generally total shoulder arthroplasty, that is replacement of both the humeral and the glenoid component, has been the gold standard. And the gold standard for a patient who has lost his cuff, whether it is young or old, obviously is the reverse shoulder arthroplasty. And there is no refuting this fact. Now, what are the other etiologies? This has already been covered, whether it is juvenile rheumatoid arthritis, AVN, post-traumatic arthritis, chondrolysis, or instability related. Everything has been covered, so I won't get into the details of that. These are the other etiologies where a patient would come with diffuse glenohumeral arthritis in a young age. What is the literature as far as the sports activity that that is permitted after total shoulder arthroplasty? This is the article from Schumann in AJSM 2010. And they found out that a total shoulder arthroplasty allowed the patients to come back to full sporting activities without significant restriction in their level of activity. However, long-term studies were awaited way back in 2010 because the fear was always you would be loading the glenoid component, especially causing a lot of polyethylene wear and loosening over time. So what is the main complication as far as the whether it is the total shoulder arthroplasty or hemi arthroplasty is concerned? It's related to the glenoid. The weak link in this construct is the glenoid. When you replace it, there is glenoid wear, poly wear, and loosening. If you have not replaced it, there can be glenoid arthrosis over a period of time, thereby requiring a revision. Keeping this in mind, there are various options. Obviously, we are talking about the anatomic design first for a cuff intact glenohumeral arthritis patient in the young age group. You've got the total shoulder where you have the regular long stem or the short stem where we had a detailed discussion. In a long stem, in a young patient, obviously there is a risk of periprosthetic fractures because they are involved in heavy sporting activities. If there's a fall, there will be a periprosthetic fracture. But there is an option of a platform stem. I'm going to show one slide about the advantages of that. So you need to always keep future revision in mind. When you talk about the hemi arthroplasty, we had a detailed chat about the stemless versus the stemmed. Obviously, the stemless is a bone-preserving operation, and it is a beautiful operation for future revision. Resurfacing basically tackles only the defective area. The main difference, obviously, between the stemless hemi and the resurfacing, which was just covered, is that you take an anatomical cut in the hemi arthroplasty, whereas you just cover the faulty area in the resurfacing, and that's what we need to remember. And as Dr. Mukesh covered, in hemi arthroplasty, in a young patient, if you want to make sure that there is something to be done on the glenoid side because of some minimal wear, ream and run is a very good option. And I will share a couple of slides on that. Biological resurfacing, I will not cover because it is not done well according to multiple studies. So this is a treatment algorithm which looks quite confusing at initial glance, and I'm going to show this slide again at the end. If you have a young patient with of arthritis with an intact cuff, you need to make sure whether the arthritic component is only on the humeral side or also on the glenoid. So that's your first thing. If obviously the glenoid is normal, you would replace only the humerus, either in the form of a resurfacing or a hemiarthroplasty. If it's an arthritic glenoid, you need to find out if there is a concentric wear or an eccentric wear, because both of them behave completely differently. If there is a concentric wear, and if it's a low demand patient, you could replace in the form of a total shoulder replacement. However, if it's a high demand, you cannot just rely on that glenoid because it can wear out, and therefore you rely on just a humeral head replacement or humeral head replacement with resurfacing. However, when there is an eccentric glenoid wear, if it's a high demand, then you need to have other options, and if it's a low demand, you need to look for total shoulder arthroplasty. Couple of articles which I will quickly show. If it's a total shoulder arthroplasty, which you are planning in less than 55 years, this is a landmark study by Patrick Denard and Jill Walsh. The average follow-up was for 10 years. The constant score improved significantly from 37% all the way to 74%. The survival was 98% at 5 years and 62.5% at 5 years. This was published in 2013. What was important for the survival was the glenoid morphology. So if it was a concentric wear, the glenoid sustained the period of 10 years, and there was a good survival, almost 90%. However, if it was eccentrically worn, then the survival was only 50%. So it's an important factor to look at the glenoid wear. Glenoid loosening is 6 times more common when the humeral head is not placed anatomically. So going back to the basics, you need to replace the humeral head anatomically. You need to make sure that there is only concentric wear. If there is eccentric wear, you need to look for other options. This is a study which has compared hemiarthroplasty with total shoulder arthroplasty. This is from the Mayo Clinic. And obviously, a lot of authors have mentioned this article. Both the hemiarthroplasty and the total shoulder arthroplasty has given excellent pain relief and function over 20 years in these young patients less than 50. However, the total shoulder arthroplasty survival has been proven to be almost 83% at 20 years, but both the categories had overall poor scores at the end of this time duration. The survival in general of total shoulder arthroplasty was better. So in conclusion, the total shoulder arthroplasty patients fared better than hemiarthroplasty patients in providing pain relief and better functional outcomes and lesser revision rates. That's the conclusion. Another study here, which has compared, this is from the Boston group, and they have compared hemiarthroplasty with total shoulder. They found failure of 22% in hemiarthroplasty, much higher than 7% in total shoulder. The implant survival again was higher in the total shoulder group, as high as 95%. The satisfaction again was higher in the total shoulder arthroplasty group, as high as 95%. So in spite of this, why is it that hemiarthroplasty is preferred? Because in general, all of us would agree that surgeons, we are worried about replacing the glenoid in view that we need to come back there in that shoulder. So we want to do minimalistic things in a young patient with heavy demand. And this has been reciprocated by the American shoulder surgeons, where there was a study done between 2000 and 2008. 58,000 odd shoulder arthroplasties were evaluated. Only 7.5% of those arthroplasties were in the age group of less than 50 years. So surgeons greatly favored hemiarthroplasty almost 64% of the times. It is specially favored if you know that your patient is a young heavy weightlifter or a heavy laborer, because he's going to wear out his glenoid for sure. And of course, in the classic indication of an avascular necrosis, where there is a unipolar change on the humeral side. So that's the classic indication for a hemiarthroplasty. Otherwise, literature generally favors total shoulder arthroplasty. This is a study which talks about avascular necrosis patients only. And this is one of the largest series. And here they have found that both of them have got similar outcomes, but the total shoulder arthroplasty for AVN has had more complications. So AVN is probably the ideal indication for a hemiarthroplasty. Total shoulder, another study from the, again, this is the repetition which I had in the previous slide. The study is from the Mayo group, and the survival of total shoulder at 20 years is much higher as compared to hemiarthroplasty. 20 of the original 75 hemiarthroplasty patients in this group required a revision before the 20-year mark. Humeral head resurfacing has been very well covered by Dr. Desai. We need to understand that this has been an implant which has had the problem, like he mentioned, of placement in varus. It does have a learning curve. It has the problem of overstuffing, and the results of the Offa-Levy group have not been reciprocated by other authors. But the advantage is that it avoids an anatomical neck cut, thereby preserving the proximal humerus. It avoids the stem placement, which is very good in young patients, so there is no risk of periprosthetic fracture. The preserving of the bone stock would help in revision, but it does not recreate the proximal humeral anatomy like a stemless hemi does. Surface replacement arthroplasty, another article this is the article from the Offa-Levy group. They have shown favorable symptomatic and functional scores at 10 years, but they have had quite a significant revision rate. 10 of the 54 patients required revision. What were the common causes? It's of interest to note this. Rotator cuff failure. Both the glenoid and the humeral component were showing some complications. There was glenoid erosion, and there were traumatic fractures in their series. Literature of resurfacing versus stemmed. I think Mukesh was asking about if there's any paper on this. So this is a paper in 2015 in International Orthopaedics. It's the only randomized controlled trial comparing the two. The humeral head resurfacing has produced inferior results compared to the stem hemiarthroplasty at the end of 1 year, according to these authors. So taking from this, you could say that even today, probably the hemiarthroplasty scores over the resurfacing for most of these cases. Coming back to the indications for Riemann run, in addition to hemiarthroplasty, we would want to do something on the glenoid. This is classically indicated when there is an abnormal glenoid morphology like retroversion, B2 glenoid, and humeral head posterior subluxation. We know that all these are risk factors for failure of both the total shoulder arthroplasty, because it becomes difficult to place the glenoid and the instability of the glenoid component. And once you have placed it, because of the eccentric glenoid loading, there is going to be wear and further posterior subluxation. To counter this, it was the idea of Frederick Matson in this landmark paper, where he did this ream and run in 30 shoulders and studied them around 3 years duration. And they could convert about 75% of posterior subluxation pre-operative to almost 59% post-operative. And they could adequately improve the humeral head centering with good subjective outcomes. This is the classic way you do it, where you actually try to create a greater radius of curvature than the humeral head. And this is the article which basically shows that there is a significant improvement after hemiarthroplasty with ream and run. But the amount of time, this is important and has not been covered today, the amount of time the patient takes to feel better is almost 20 months. So you need to counsel the patient that it's going to take significant amount of time and a painful rehabilitation course before which they start getting the benefits of this procedure. And this is the article which has compared ream and run outcomes to total shoulder arthroplasty. As I just mentioned, ream and run has got more difficult and slower recovery time as compared to the total shoulder patients who do extremely well very fast. And therefore, the ream and run patient should be counseled regarding the prolonged rehab and the recovery time. And the important cause for failure is the significant postoperative pain, which some patients may not be able to tolerate. Just a single slide of the resurfacing, which has not done well. And multiple studies have shown that whether it is fascial lata, whether it is a dermal allograft, it has not really done well with hemiarthroplasty. And clinical outcomes of comparing the hemiarthroplasty with the biological resurfacing. Again, there was very high failure rate with biological resurfacing, and hemiarthroplasty alone has done well. This is the algorithm which we just discussed. So I think we have a fair idea. We need to look at the glenoid component. If the glenoid component is not arthritic, we can rely on resurfacing or hemiarthroplasty. We then need to look at the concentric or the eccentric wear pattern and the demand of the patient. Higher the demand of the patient, you would make sure that you do not replace the glenoid component and do something like a ream and run and rely on humeral head resurfacing or hemiarthroplasty. Lower demand patients, even if young, the total shoulder arthroplasty has done extremely well. In summary, there is no perfect reply for arthroplasty options in the young shoulder patient, as we have all seen today. Everybody, as per their experience and as per the literature, will have to decide what is best for their patient. Surgeons should decide based on the literature, patient profile, and the anatomical factors of the proximal humerus and the glenoid. Overall, however, literature is in favor of total shoulder arthroplasty in younger patients compared to hemiarthroplasty, except in heavy demand patients and in avian, like I discussed. Glenoid side is the weak link, and we need to keep this in mind because this patient is going to come for revision in future. Ream and run is ideal for the abnormal glenoid morphology. There is no validation for resurfacing. Although it's a very intriguing option, it has generally performed inferior to the stemmed hemi. If the patient, we rarely come across young patients who are having abnormal cuff morphology, reverse shoulder arthroplasty in young patients. This is the article from Mark Frankel, where they have studied the results in patients younger than 55 years, and they have had good outcomes overall. And like Mukesh mentioned, even with pre-existent surgeries, when you have revised them to a reverse in younger age group, their outcomes have been matched to a primary reverse, according to Mark Frankel. Future trends, we now are looking at computer-assisted and virtual planning. This is some of the literature on this. As far as possible, if you could preserve the subscapularis and do away with the fatty infiltration, outcomes are going to be good. We have had a detailed chat about short stem versus surface replacement. The platform stem probably is not touched today. We need to keep in mind that in some cases, if you are concerned about a future revision in near years, then you could do a platform stem wherein you could just replace the glenoid component in future. And the concept of hemiarthroplasty with pyrocarbon, although not available to us today, but this has shown to be a good option for young shoulder arthritic patients. Thank you.
Thank you, Nagraj.
Very well covered, Nagraj.
Yeah.
Except for biological reconstruction of the glenoid surface with allografts, both for the humerus as well as the glenoid with meniscal transplants. I don't know. Have you read more on that?
Yes, sir. As I mentioned, Suman Krishnan was the first person to have mentioned it and given a series of it. along with his partner.
Only interposition of tendo Achilles and this, but Brian Cole has done. You see, he takes allografts of the humerus as well as the tibial plafond for the glenoid, head for the head, like that. No, and sometimes he does alone only for the head, and then if the glenoid surface is good, he puts a meniscal transplant all around the glenoid.
Yes, just to mention, sir, you're absolutely right. This is an area which is of a lot of interest because you're putting a biological material in the glenoid which can prevent the wear. And therefore, there have been a lot of studies that have been done on it using fascia lata, using dermal allografts. However, the long-term survival, short-term is very good. 1 year, 2 year, 3 year survival is very good. In the long term, these have not survived and therefore completely gone out of repute in the shoulder fraternity. However, I think in the young patient, for example, when you're doing instability surgeries, not arthritic patients, recently I think I saw a presentation from Ivan Wong, where there is a revision of a failed surgery. So there's a failed Bankart, there's a failed bone block or a failed Latargia, and there is a lot of capsular loss. As a replacement of the original capsule, people are trying, again, it's coming back slowly for this category where they're trying some sort of a patch. Like we know superior capsular reconstruction has done well for the rotator cuff. Even on the glenoid side, they're trying it. But that's it as far as literature is concerned. In the arthritic patients, it's not doing well.
Thank you, Nagraj.
And what is about biological reconstruction using the allografts in young people? Sanjay?
The biological reconstruction, as per literature, everyone has given way.
No. You are talking about only fascia. I'm talking about allograft.
Allograft, okay.
As well as the plafond, tibial plafond for the glenoid. That is the latest. 2000.
No. I think, Antao sir, you are talking about probably for the walls 3. Sanjay, probably sir is talking about the walls 3 lesion when there is, you cannot go ahead with your, even with the wages you cannot correct. Then you have to probably take the tibial plafond and you have to build the bone. I think Sanjay, he is talking of the walls 3 and probably 2C.
Nicholas is talking about bone transplant.
Yeah. Yes.
We are still far away, Nicky boy. I love you, but
I love you too.
Just,
think over.
Because we don't have a good bone bank where you can order a proximal humerus, you know.
It will come. Why not?
It will, of course. We hope so, yeah.
So I think Nicholas sir, you can Nicholas sir from your Maharashtra Orthopaedic side and the Bombay Orthopaedic Society, you can just summarize the whole academic phase today, and IPS you will conclude the thing.
First of all, I must thank on behalf of the MOA and IOA and BOS, the faculty who have taken so much time and trouble to educate us and inform us up to the latest in young arthritic shoulders, the causes, the options available, and how to go ahead and looking at the future. Even doing the review of the merits and demerits of different procedure. That's like guiding you right away to do what needs to be done. Finally, that the treatment has to be tailor-made for the patient and not really the pathology alone, but what patient wants and what is the function and what he wants after the surgery, his requirements. And that is very well brought out. I must thank you for your time spent in digging up the literature to educate us, and the time spent to making lovely presentations. As usual, Sanjay and Ashish, and now the youngsters, Mukesh and Nagraj. Of course, inputs from Swanendo is always there, and IPS.
Thank you, sir. We are just following your footstep. You are the guru in the Indian Arthroscopy Society. We are just following we are fulfilling your dreams.
Sorry, Abhijeet, I forgot you, huh? You are there.
No, Abhijeet was also there.
Yes.
Kale was there, yeah.
It was pleasure joining the meeting and enjoyed thoroughly.
Abhijeet, thank you.
Thank you very much. Conclude. Thank you.
Bye-bye to everyone. Bye-bye.
Bye.
Bye-bye.
Bye.